Dear Chair and organizers, thank you so much for inviting me. Dear colleagues, it's really nice to see so many of you still here in the audience. So, preventing venous thromboembolism during pregnancy and puerperium is an important and challenging task. The evidence is scarce. We have no large-scale RCTs, so we base most of our evidence on observational studies. I will base my talk on the last updated guidelines from the American Society of Hematology, published in November 2018, from an international group of very high qualified colleagues. So here are my disclosures. So I will talk about prophylaxis after previous venous thromboembolism, then prophylaxis with inherited thrombophilia without previous VTE, prophylaxis and other risk factors, duration of prophylaxis, and a couple of words of dosing. The incidence of pregnancy-associated VTE is, according to one of the last meta-analyses, 1.2 per 1,000 pregnancies. The case fatality rate is 0.68, and the risk of a major bleeding is around 1%. And in this figure, you see the distribution of VTEs during pregnancy, the pregnancy weeks during the x-axis, and number of thromboses at the y-axis. And as you see, the absolute highest risk of VTE is the first 6 weeks postpartum. So, what is the risk of recurrence if you have a history of one previous VTE? The overall risk is 4.27%. Mark Rogers published a pooled analysis of the present evidence in 2014, and he looked more deeply into this, and he showed that if you have one previous VTE and don't take antepartum anticoagulants, then your risk is 4.2%. If you take anticoagulants, the risk is 0.9% antepartum. And if you don't take anticoagulants postpartum, the risk is 6.5%, and with anticoagulation, 1.7%. So, is it a difference whether the previous VTE was a provoked or an unprovoked one? And now we're talking of only antepartum thrombosis. So, if the previous thrombosis was unprovoked, the risk is 3.6% of having an antepartum VTE. If it was provoked, but without hormonal provocation, it's 1%, and with estrogen-associated provocation, 6.4%. So the ASH recommendations are 6 weeks of postpartum prophylaxis for all women with previous VTE, and the women who have previous unprovoked VTE or an estrogen-associated VTE are recommended antepartum prophylaxis. But if you have a previous provoked VTE, which is not estrogen-provoked, then you may not take the anticoagulation antepartum. So, then you can take up your leaflets. This is a case. It's a woman, 34 years old. She's IVF pregnant. It's her first baby. She has a heterozygous factor V laden and a mother with a previous VTE. So, would you give this woman antepartum prophylaxis? Yes or no? We're voting. Yes. Wow, 90% for yes. Okay, so then I think the result of the next question, postpartum prophylaxis, again, 100% yes. Good, thank you. So, what would ASH recommend now? Well, I'll come back to that. First, I'll talk a little about hereditary thrombophilias and the risk of VTE. The overall risk, if you have factor V laden, is an odds ratio of 7.28 for a VTE. If you have a prothrombin gene mutation, the odds is 5.43. And to go into a little more detail, I want to present one of the last case control studies from UK group, Garrar and co-authors. And here they stratified by age. So the first column is below 35 years, and this column is for the ones over 35 years. And here you can see that if you are heterozygous factor V laden, the risk of having a VTE is 0.5%. If you are homozygous factor V laden, the risk is 2.2%. If you have a heterozygous prothrombin gene mutation, the risk is 0.4%. And if you have a combined heterozygous factor V laden and prothrombin gene mutation, the risk is as high as 5.5%. And you can see that the numbers for the ones over 35 are almost 50% higher. So these are the recommendations from the new guidelines, and the quality of evidence is low on all these recommendations. It's a busy table, and I'll guide you through. So if you are heterozygous for factor V laden or for prothrombin gene mutation, antepartum prophylaxis, and regardless of family history, antepartum prophylaxis is not recommended, and postpartum prophylaxis is not recommended. If you go to antithrombin deficiency, there you see that if you have a family history, you are recommended both antepartum and postpartum prophylaxis. Without family history, no prophylaxis, antepartum nor postpartum. If we go to the homozygous factor V laden, then it is regardless of family history, ante and postpartum prophylaxis recommended. And the same for the combined thrombophilias, regardless of family history, both ante and postpartum prophylaxis. Okay, then I will say a couple of words of other risk factors, and for the antepartum risk factors, I've chosen the ovarian hyperstimulation syndrome. And this is one of the strongest risk factors antepartum, and the estimated incidence is 0.7 to 10%. And the table here is from a Swedish cohort study from 2012, and they showed that if you have a fresh IVF trial and or treatment, you get a severe ovarian hyperstimulation. Your odds ratio is almost 100 for getting a venous thrombosis in this period. And the low molecular heparin is cost effective in these patients, and the ASH recommendation is in women undergoing assisted reproduction who develop severe ovarian hyperstimulation syndrome. ASH suggests prophylactic antithrombotic therapy to prevent VTE. So to the postpartum period. Here again, we are lacking large RCTs, but we have a lot of observational studies, and there are some published risk assessment models. And here is one model who was published in 2016 in BMJ from Sultan, and this is a collaboration from a UK and a Swedish group. And then they made a risk prediction based on 433 UK pregnancies and came up with this list of risk factors, which is previous VTE, thrombophilia, family history, varicose veins before delivery, cardiac disease, renal disease, inflammatory bowel disease, smoker, postpartum hemorrhage, stillbirth, postpartum infection, diabetes, and they put in parity, age, BMI, and delivery mode, and they calculate predicted probability of VTE of the separate patient. And they validated this model on 662,000 Swedish pregnancies and concluded that the prediction model performed better than the current UK guidelines, representing by the RCOG guidelines and the Swedish guidelines. So a couple of words to dosing. There is one ongoing RCT, and that's the high-low study, which is led by Saskia Middeldorp in Holland. And this is for women with a previous VTE. And it is an international open RCT, and they are randomized to standard versus weight-adjusted intermediate doses. The main outcome is recurrence VTE, and the number of inclusions should be 1,000 to be powered enough. And now there is almost 800 women included in this study, so that's pretty good to be pregnancy and VTE study. And the current recommendation from ASH is antepartum pregnant women who require prophylaxis. ASH suggests against immediate dose compared with standard dose, and postpartum women who require prophylaxis, ASH suggests either standard or intermediate dose. So what about the duration of prophylaxis? You see again the same figure as I've shown before, and the ASH have put a certain threshold of giving antepartum prophylaxis of 2% and the threshold of postpartum prophylaxis of 1%. And if you have are recommended antepartum prophylaxis, you are recommended to start first trimester and continue the whole pregnancy and postpartum. And if only postpartum prophylaxis, then it's recommended 6 weeks with low molecular weight heparin. So, back to the case. The woman is still 34 years old. She has an IVF pregnancy. It's her first baby, heterozygous factor V laden, and a mother with previous VTE. And antepartum prophylaxis, well, my answer is no, and ASH's answer is absolutely no, but you always have to consider additional risk factors. When it comes to postpartum prophylaxis, most national guidelines will recommend postpartum prophylaxis for 6 weeks for this woman. But when it comes to the ASH guidelines, it's actually not recommended with prophylaxis, but always consider additional risk factors. I know that you don't agree with this, so, well, here we are. So, to sum up, the level of evidence is low to very low behind most of these recommendations. So we have to do shared decision-making with the patients, and that is really important. And the changes in the 2018 ASH guidelines, if you compare them with the ACCP guidelines from 2018, is that heterozygous factor V laden with the family history, they now suggest against postpartum prophylaxis, whereas homozygous factor V laden, regardless of family history, is now suggested with antepartum prophylaxis. And the combination of thrombophilias, regardless of family history, they suggest antepartum prophylaxis. And VTE prophylaxis with low molecular weight heparin is the preferred standard of care by all guidelines in pregnant women. Thank you.